Buenas tardes, good afternoon. Me llamo Mara y mi cointérprete es Susan. My name is Mara and my co-interpreter is Susan. Este evento será en inglés y español. Para escuchar la interpretación al español, por favor seleccione el canal para español. Si usa computadora, haga clic en el globito con interpretación y luego seleccione español. Si usa la aplicación de Zoom en su teléfono o tableta, haga clic en los tres puntitos, luego interpretación de idiomas, luego español y por último finalizado. Today's event will be in English and Spanish. To hear interpreting into English, please make sure to select the channel for English. If you are using a computer, click the globe icon that says interpretation and select English. If you are using the Zoom app on your phone or tablet, click on the three dots, then language interpretation, then English, then done. This last part will be in Spanish. Para las personas bilingües, si se conectan a un canal, por favor, hablen solamente el idioma de ese canal. Si usted no se conecta a un canal, siéntase libre de hablar en español o inglés como prefiera. Gracias por ayudar a crear este espacio multilingüe. Thank you for helping to create a multilingual space. Back to you, Gustavo.
Thank you, Susan. Evelio, Roxana, good to have you here. Thank you, all the panelists, to join us. And apologies for the delays, but we're ready to start. So we're going to start with a little bit of some context. And for that, I'll leave Evelio and Roxana.
Hello, everyone. My name is Evelio Escamilla. I'm a senior research associate with the Latino Commission on AIDS, and we are part of the Institute for Latinx Health Equity at the website listed below. Roxana?
Hello, everybody. My name is Roxana Guzman. I'm also a senior research associate at the Latino Commission on AIDS, and we also work with the Institute for Latinx Health Equity. Thank you for joining us. You want to continue introducing the panel?
Yes. Ms. Hernandez, would you like to introduce yourself?
Sure. Thank you. So my name is Lisandra Hernandez, and I'm the physician assistant at Centro Ararat, and we have been working with an aging population with HIV here in Puerto Rico.
Ivan?
Yes, my name is Ivan Baez. I'm the mental health supervisor in Centro Ararat in Puerto Rico, and I'm working with some initiatives related to people living with HIV.
Mark?
Yes, hi. My name is Mark Brennan-Ing. I'm the Director of Research and Evaluation at the Brookdale Center for Healthy Aging at Hunter College. A large part of my research focuses on older adults with HIV, including older Latinx adults.
Dr. Patel?
Hi, everyone. I'm Sheetal Patel. I'm an infectious disease physician here in Houston, Texas at Baylor College of Medicine. I've been taking care of people living with HIV for now 20 years. And my other hat, I also direct the AIDS Education Training Center at Baylor College of Medicine. And our big initiative in the last few years has been really how to help our patients aging with HIV, and how do we build capacity and build models that can help take care of helping people live long and strong.
Okay, so we're gonna go ahead and present. Can you see the screen right now? The title screen?
Yes, we
Yes?
do.
All
Yeah.
right, great. So we're gonna go ahead and go forward with the slides, and then we're gonna go quickly into a very, very informal conversation about the topic and kind of exchange ideas about what's going on in different jurisdictions. And we all have our separate expertise. And we just actually here and we're in Fort Worth, and we just finished a workshop with our partner here in Fort Worth talking about this topic. But it's really interesting to hear from different jurisdictions, especially from Puerto Rico. As a researcher also, how do you see this evolving? And of course, Dr. Patel as a provider and also as a trainer for the South Central AETC. Go ahead, Roxana, you want to start?
Yes. So thank you, everybody, for joining. First, okay, so interpretation slides. Let me move on. There's no conflict of interest. So first, I'm going to set the tone before we open it up to a rich conversation with our panel. Because the National Latino AIDS Awareness Day is coming up, we wanted to focus on an example of those living with HIV among the Hispanic population. In the chart you see before you, we have Hispanics living with HIV in the US and Puerto Rico from 2008 to 2023. As you can see, those dark blue bars at the very bottom represent the aging population from 55 and older. As you can see in 2023, that has grown to almost a third of those Hispanics living with HIV. And this is just to represent a growing, ever-growing projection of the aging population. Of course, several racial and ethnic groups might have different HIV epidemic histories. But for Hispanics, this is just an example, and we're really here to talk about the infrastructure, but this is just an example to kind of set the tone, see the scope and the magnitude of those living with HIV. Alrighty, this chart before you is a little complicated, but I want to really share the diversity of those living with HIV. We have a lot of variations across these groups. Again, those darker bars in blue. Those darker bars in blue represent those 55 and older. As you move towards the bottom of the chart, we break it down by sex, sexual contact at the time of diagnosis, and then IDU, right? And this is just to really represent a heterogeneous HIV epidemic, right? This could start, part of the conversation we're going to have is learning how to tailor and segment populations to better approach these different populations, different intersectionalities, because they all require different approaches and messaging. I'm going to move forward. Again, we will have a lot of variation across states, right? We probably have many participants representing large Hispanic populated states. And those, as you can see, about 34.4% of Hispanics living with HIV are 55 and older. And we see the variation across all these states, of course, with different number of cases, representing a different magnitude, but also the impact represented by the percentage, right? And of course, all these geographic variations will represent different states with different capacities and different infrastructure, right? And so we would love to hear from the panel on how we can move as a country and Puerto Rico to address this ever-growing aging population, not only for Hispanics, but for those aging with HIV. This is just a report that we recently released addressing HIV and aging among US Hispanics. Please, whenever you get a chance, scan the QR code, and we really talk about not only about HIV outcomes, we talk about the workforce, and we also are I will show you in a bit a systems approach also included in this report. And this will help guide our conversation later. All right. So the infographic before you is just a macro perspective of the systems approach. And we require a systems approach because after looking at the epi data and the magnitude of an ever-growing population, we understand that there is a demand right now that requires rapid response and an ever-growing demand in the future that requires preparedness plans, not only for the aging population, but for different segmented racial and ethnic groups and so on. There is an urgency to develop these rapid responses and preparedness plans, not only at the local, but at the state and federal level. And so this systems approach really tries to capture that macro perspective. You have client needs at the very top. Those needs will always be present, which influences the programmatic needs at an agency. And then those agency needs will influence the institutional ones, things like capacity building and technical assistance. And all this to say that the infrastructure needs, we're talking about like at the federal level, really has to capture all these needs, all this demand in order to attend to those clients and those living and aging with HIV. Thank you for joining me in this kind of not only sharing the data, but also trying to keep in mind this systems macro approach when engaging in our conversation. I will open up to the panel in just a bit with some questions. Thank you for the panel for joining us, and let me move on to the first question. All right, and I'll have Evelio and Gustavo take it over with me.
So Gustavo and I will manage the moderation of the discussion, but we really want a very robust discussion among our panelists. And Gustavo, you can take the first question and manage that discussion.
Sure thing. Thank you, everyone. So, as we've heard, there's a wide variety of panelists here from different regions, from different expertises. So, we would like to hear from a little bit from all of you. What are some infrastructure recommendations that health organizations seeking to integrate HIV, behavioral health, and aging services could receive to address key infrastructure?
You want to direct the question to someone?
Anyone who wants to jump in, feel free to. I think mental health, we have Dr. Ivan around, so maybe let's start with Dr. Baez. Around mental health, what infrastructure recommendations are there?
Pues nada, saludos. Tal vez puedo comenzar la conversación que yo creo que la mayoría de los que estamos podríamos tal vez estar de acuerdo. Cuando hablamos de infraestructura, estamos hablando de elementos como es el aspecto físico, ¿verdad? De una organización, pero también está la infraestructura organizacional. Y creo que como se comienza a trabajar es haciendo un análisis, ¿verdad? Una evaluación de qué es lo que tengo en este momento y hacia dónde deseo moverme, porque es lo que nos va a ayudar. ¿Qué servicios yo estoy ofreciendo integrados en este momento en términos de ser una clínica que atiende a personas con VIH? ¿Y cómo quiero integrar servicios adicionales que tengan que ver con servicios geriátricos complementarios a la población? Entonces, eso nos va a llevar ¿verdad? A hacer el análisis de cuál es el espacio físico que tengo. Por ejemplo, es posible que si quiero hacer una evaluación visual de cada uno de los participantes y lo voy a hacer de manera tradicional, necesito un espacio físico para ubicar, ¿verdad? El artefacto para medir con las letras, y eso implica, ¿verdad?, que necesito un espacio físico posiblemente adicional. Pero adicional a esto, en términos de la estructura organizacional, con cuántos empleados cuento, cuántos de ellos están adiestrados, voy a estar añadiendo empleados a la organización o con los que tengo es suficiente, ¿verdad? ¿Cuál es el apoyo que tengo de la más alta gerencia de la organización? Estamos preparados, ¿verdad?, para dar este paso y sobre todo para no tomar mucho tiempo y poderle dar la oportunidad a mis compañeros también en términos de acuerdos colaborativos, con qué acuerdos colaborativos cuento, si son robustos, si necesitan fortalecerse, y poco a poco entonces irnos moviendo hacia lo que yo llamo lo mínimo que necesito. ¿Qué es lo mínimo que yo necesito? ¿Voy a estar integrando personal o voy a estar adiestrando el mío? ¿Necesito realmente un geriatra o necesito un asistente médico? Para salud mental necesito un psicólogo o tal vez lo pueda hacer un manejador de casos clínico adiestrado que pueda trabajar. Yo creo que esa es la parte, ¿verdad? La parte inicial de donde podemos partir, y entonces espero darle la oportunidad a mis compañeros para que también puedan expresarse sobre el particular.
Dr. Patel, you could share a little bit about you working with multiple organizations in your role as an AATC trainer. How do you see these recommendations arising, or what's the need out there?
Yeah, for sure. And I agree.
Sí,
Part of
una de
the
las cosas, ay, perdón. Sorry.
was it directed towards me or?
Una de las cosas que nosotros aprendimos a través del proceso es que se debía aumentar lo que es la empatía para la población con la que vamos a trabajar, ¿verdad? Lo que podría ser en términos de adiestrar a nuestro personal para que sea culturalmente sensible. Por lo tanto, antes de comenzar a trabajar, nosotros promovimos en el personal que se adiestrara, promovimos la discusión, ¿verdad?, de cómo podemos atender mejor a población que envejece con VIH de 50 años o más. En términos de los motivamos a tomar webinars que en aquel momento Rutgers University estaba ofreciendo todo un currículo que pudimos entonces adiestrar a nuestro personal adecuadamente, que pudimos tal vez contar con el apoyo de la Escuela de Medicina de la Universidad de Puerto Rico, que nos dio acceso a materiales, a proyectos que ellos estaban implementando en ese momento. Y todo esto nos ayudó, ¿verdad?, para, previo a la implementación de los servicios, poder tener esa infraestructura en términos organizacionales que necesitamos para comenzar con el pie derecho a poder ofrecer servicio a nuestra población.
Dr. Patel?
Perdón.
Dr. Patel?
Yeah, and I agree with all that was just said. To really develop infrastructure, one, you need awareness across the entire organization, right? So what is the landscape of caring for someone living with HIV? What is it now? What is it going to be in the next decade? And from every level of the organization, of who does eligibility, who checks in an individual at the clinic, to the pharmacy, to the lab, to every person that is touching that patient on that patient journey, because there are needs that are changing, and how you approach patients. So our HIV care models have really kind of approached patients in one goal, and that is, are you getting medication, and are you getting viral suppression? And that's the one goal. And our goals are changing. So having everyone understand what those new goals are important to get every buy-in throughout the organization. And then awareness and training. I completely agree on the cultural kind of humility and competency of understanding what changes as people age, and where do we need to be a little bit slower in explaining things, in can our forms be easier to fill out, simple things that can really make a difference in keeping patients in care, retained in care, and happy with their care, are really important. And then the third thing I'll add is looking at what we have in place already and saying, do our assessments need to change? Do our questions that we ask? So we are working with case managers across 5 different organizations to do what we call geriatric case management. And those assessments were developed many years ago with one end goal of viral suppression. But do those assessments need to have more granular questions around aging with HIV, whole person directed assessments, and how to optimize outcomes from comorbidities that are increasing as individuals age with HIV?
So now we have the second question here. What are the public health system needs? How can we actually change some of the local public health infrastructure for each locality? The integration of services at the system level, public health system levels. These are also, we're talking about the organizational needs. Now we're going to talk about the infrastructure needs of a public health system. Mark, would you want to add something to this question?
Sure, but I kind of a blend with the previous question, if I may be so bold.
Of course.
I think one of the issues here when you're talking about integration, when you're talking about these infrastructures, particularly when it comes to mental health and particularly when it comes to aging, we just lack the infrastructure now. It's very inadequate. And if you talk about integrating that, you're talking about integrating some inadequate systems. I think our HIV care and treatment system is in pretty good shape. Fingers crossed that that doesn't change as all these budget things are sorting out. But for example, we've known for decades now that older people with HIV have very high rates of depression. It's not being addressed. It's not being treated anywhere. This has just been persistent. I was doing a pilot study with the local ASO. We were screening people for depression for an intervention we were testing and then referring them back to their mental health clinic. They were completely overwhelmed within 2 weeks of us just doing screenings at one of their programs. We just don't have the capacity there. The same problem with aging. A few years ago, we had, I think, somewhere around 12,000 geriatricians in the United States. For the entire United States, even as our population is aging, including people with HIV, that number now is less than 9,000. So those numbers are moving in the wrong direction. So part of this is we need to invest in those segments of the infrastructure. I think that's going to be necessary if we're going to start having these conversations about public health. In terms of public health specifically, we're seeing funding being eliminated, like the HIV prevention program at the CDC. And also, I mean, in addition to the funding challenge, I think is kind of the mindset challenge is that the people directing public health at the federal level don't seem to really get the idea of public health or endorse it. And we have to address that before we can move any of this ahead.
Gustavo, maybe perhaps you and Ms. Hernandez can address the issues. You've seen the stuff that's been going on in New York City, but you also have the perspective of what's going on in Puerto Rico. Maybe perhaps you and Ms. Hernandez can address that issue, the dichotomy of a system in New York City and then also what you see in Puerto Rico.
Yeah, thank you, Eva. I just wanted to pull Dr. Hernandez right because when we talk about aging and we talk about healthcare, for many folks in the U.S., they can think Medicare and Medicaid and that transition, right? The reality of Puerto Rico is a little bit different on what do we have access on Medicare and the access to the money. So specifically, Dr. Hernandez, right? What are you seeing in Puerto Rico, right? Specifically around public health infrastructure. What are enhancements that are needed as a physician assistant? What kind of enhancements do you physician assistants need to be able to help transition folks who are aging with HIV into more aging or geriatric care?
Yes, well, actually, I just attended to a participant in our clinic this last Monday, and she's new to Medicare. And when she arrived to the clinic, I mean, we already had the process of implementing, new services and new screenings because we noticed that we were lacking some screenings and services to the population aging with HIV. So what we did with that, we incorporated those services like for the past 3 years to now. So we are already running, a complete model of care. We are actually using the 5 M's that we all know, from the AGS Society. So we're already working in that. So when this lady arrived last Monday, I offered all the screenings and the accessibility, to perform what she needs on her care. But what I notice is that when they come new to the Medicare system, they're a little bit lost on how to navigate those resources that they have. So what we do in our clinic is to contact the Medicare alliances, the ones that we know the advantages. And so we locate them and we bring them the brochures and we share with them what it covers for them, and also navigate with them what are the screenings and the services that are needed for them to have a proper continuation of care. So we also talk about a little bit about cultural competency, like integrating case managers that can act like navigators for the patients and connect them with the needing of the resources and ensuring that continuity of care. So we also try to, have social support services in that process, also develop programs that provide nutritional support. We also have nutritionists in our clinics. Mental health services, we also fortunately we also have mental health services and peer counseling to create this holistic approach to health from a social support side. And we also attend the affordable housing because it's important for them in this public health infrastructure that is needed to address the social determinants of health by expanding access to affordable housing and support individuals living with HIV or aging individuals with behavioral health issues also. So I think is like everybody has said, is very comprehensive. Is we need integrations of different systems, but I think that we need to identify the areas that is scarce right now that we are not attending, such as training providers also is important in this process of public health. We need to train the providers. We need to train the people that are in the healthcare system to learn how to treat and manage both HIV and behavioral issues, especially within aging populations. Just as Dr. Patel told us, it's very specific, it's different, and it's important, to address it. And also cultural competency, training for healthcare providers in cultural sensibility, especially for aging populations from diverse backgrounds, to ensure respectful, person-centered care.
Thank you, Dr. Hernandez. And I heard quite a few things, specifically when we're talking about this dichotomy between HIV offering services and non-HIV offering services. Right,
Yes.
as you mentioned, Centro Arad does have HIV services. So in these spaces, we're used to have mental health, and we're used to have peer support, and we're used to have all this ancillary support that still we need more support of that, but that might not be the reality on a non-HIV centric space. And
Yes.
folks who are aging with HIV into those spaces, they might have that shock. So places like Ararat or AC, these other places are places that potentially non-HIV focused entities could look to get support,
Yes.
learn from, knock on the doors and ask for support. Because there's a history already ongoing on how we care for folks, especially now as they're aging. So thank you for that.
Anybody else want to contribute to this answer on the current public health infrastructure?
Bueno, en términos de lo ideal, sería indudablemente contar con los recursos necesarios. De no poder tener esos recursos necesarios porque no contamos, ¿verdad?, con el andamiaje económico para poderlos tener, pues entonces la segunda alternativa sería el servicio de referidos, de establecer todos estos acuerdos colaborativos para poder hacer llegar al paciente a un lugar donde le den estos servicios. Indudablemente, tanto lo que está hablando Mark como la doctora Patela, hay unas necesidades específicas, ¿verdad?, que obviamente tenemos que tomarlas en consideración. Sabemos que hay una crisis de profesionales y en Puerto Rico no es diferente. Sin embargo, pues hay que intentar al máximo trabajar con los recursos que tenemos en la identificación de estos recursos para poder promover que nuestros participantes tengan el servicio que necesitan. Y maximizar en términos de los recursos que tengamos, tanto en nuestra organización como los recursos que hay externos para poder servir a nuestros participantes.
Dr. Brennan, do you see anything in the research area that you feel that needs to be addressed more?
Yeah, when we talk about cultural competency, we kind of focus on one aspect of identity. And I think we need to think about how that training might address intersectional identities and intersectional stigma. So if we're talking about aging, HIV, and mental health, all three of those things are stigmatized. There's a lot of ageism in our healthcare services. That's going to create a reluctance for people to be engaged with healthcare, either if they feel like they're being discriminated because of their age or their HIV or their race ethnicity. And, you know, in many cultures, the stigma around mental health is even more severe than the stigma around HIV. From a research side, it's been very hard to kind of disentangle all of this because you really can't reduce intersectional stigma to numbers. But no one's really addressing how we would address that in terms of cultural competency. And I think it's till we start asking that question and digging into that a little bit, we're not going to be able to do that.
Dr. Patel, anything you want to add?
No, I mean, I think it's a very, as Dr. Green said, it's very complicated, and there's a lot of intersectionality in it. We usually often talk about it in silos, right? When it really is all ingrained together, and we need to recognize that and approach it in that manner.
Gustavo, you want to take the third question?
Of course, and just to wrap it up, and we kind of touched base on funding, but what state and federal policy, what recommendations, as you folks who are on the ground, providing the services, seeing the day-to-day, navigating the systems, what are some recommendations that you believe are central to ensuring integration of HIV, aging, and behavioral health services? And I would like to start specifically, once again, with Dr. Hernandez as a physician.
I mean, I think in our clinic, Dr. Bias is more knowledgeable in that part, but I will say that is very difficult. You know, if we want to construct an infrastructure that attends so many different things, I mean, everything is moved with money, and we all know that, you know. And we have the providers, so we have the services, we have all the systems, and they need to be sustainable. So I would say it's very difficult, the funding part, but we need to incentivize the multidisciplinary care. You know, federal and state funding should be used to incentivize health organizations to offer multidisciplinary care that integrates HIV care, behavioral health, and aging services, because that is the future. I mean, we need to move towards that. It's not negotiable. We need to find a way, you know, for them to realize that this is very important and needed. You know, grant programs for service integrations, establish grants that help local health departments, community organizations, clinics that integrates HIV, mental health, and aging services. This could include funding for training, you know, infrastructures, upgrades in the EHR systems, which is also needed, and collaborations of care models, you know, support community-based organizations. Funding should be directed to CBOs that could work directly with marginalized populations. I mean, I think it's very complex, but we should be striving for it. I think we should continue here in Puerto Rico. federal fundings may be complicated sometimes also, and sometimes the local organizations are the ones that are pushing forward all the time, sustaining, maintaining the communications, maintaining the services. Sometimes it seems like miracles happening every day. So we do need the integration of the higher levels for this process.
Thank you. And certainly, physicians and often those of us in the field are making magic happen every day.
Yeah.
Dr. Patel, specifically from you, what funding recommendations? We know we talk about training, but what are some funding recommendations?
Sí,
Are you
quisiera añadir un poquito, ¿verdad? Que sabemos que a nivel estatal y federal, nosotros el trabajo que debemos estar realizando es cómo podamos influenciar para que la realidad de las personas que envejecen con VIH cambien. Sin embargo, es una situación plural, como dice la doctora Patel, ¿verdad? De diferentes sectores. Y nosotros tenemos que entonces también pensar en lo que podemos hacer nosotros, de qué manera podemos apoyar más a ese paciente. Una de las frases que utilizamos, que la estábamos hablando ayer justamente con los pacientes, es que información es poder. De qué manera yo puedo empoderar a ese participante para que él sepa dónde puede ir a buscar más recursos, dónde puede ir a buscar más ayuda, sin olvidar que hay un estigma de por medio y que en este caso, se lo puedo decir yo, que no solamente estoy trabajando con la población que envejece con VIH, sino también con salud mental, que sí es otro sector que está altamente estigmatizado en la población. Pero es intentar que los que pueden hacer cambios en esa política pública con relación a los fondos hagan su parte, mientras nosotros también como humildes obreros de la población hacemos nuestra parte y buscamos la forma en que ellos se conecten a los servicios, ya sea con organizaciones que pueden ofrecer estos servicios, ya sea con el plan médico, lo que le pueda cubrir, lo que no le puede cubrir, lo que no te podemos cubrir por aquí, como tal vez la misma clínica puede ayudarte en esta área, ¿verdad? Porque tenemos que colaborar todos, porque como estamos hablando desde el principio, es un sistema, es una situación sistémica y tenemos que trabajarla a nivel sistémico.
Thank you, Dr. Baez. Dr. Patel, go ahead.
I just wanted to add to the conversation a little. There's a concept of a medical home for patients, right? The need is now. And in HIV care, we already know that a biological age and chronological age don't match, and that there is people can age anywhere from 5 to 10 years faster than their general population. And so there's a concept of medical home where you have a home and you have services in that home. So state and federal policy and funding recommend, can we create a medical home network, right? Because all services, ideally, it'd be great to have all the services in one location, but realistically, that's not possible. And mental health services, services for HIV care, services for comorbidity care, but can we create models with funding and policy support that creates networks? So this is your mental home network that's available to you through the different resources. Could it be Medicaid, Medicare, Ryan White, other funding resources? But I would love to see policy go towards a network development.
That is so important. Navigating the system is a big downfall. It makes our system fragmented. We need to really think about that. The networking needs to be tighter. We're at the 51 minute. In closing, in 10 years, what do you see successful integrated systems look like for aging, for persons living with HIV? In 10 years, what do you see? What would you like to see in 10 years something different? Let's start off with Dr. Brennan.
Sure. So there's a concept that's been floated around New York City in terms of aging services called no wrong door, which basically whatever service you try and access, that organization has the capability of referring you to the right provider or getting you what you need. I think if we could organize our health and social services more around that model, because we also need to integrate social services with healthcare services, especially when we're talking about older adults, because there's a lot of psychosocial needs and issues that really affect their ability to engage in treatment and getting their families engaged in that plan too. So that's why I'd like to see a lot more kind of centralized intake for people that would get them to the right place.
Wonderful. That's a great idea. Ms. Hernandez, what would you like to see in 10 years different?
Well, I'm just going to take what Dr. Patel said. I loved her concept of, the networking. So I would love to see a system, that integrate the service delivery models, that, the data sharing, the electronic health records that, connect. I would like to see transportation and accessibility for older adults. I would like to see, more development and training of the workforce, cultural competency, care coordination hubs, maybe integration of case management, affordable housing, social support services. I mean, it's 10 years. We can do all this. Medicare and Medicaid expansion, considering that it's very comprehensive and there's a lot of things to, take up on. Support for integrated care models, data of privacy and security policies, etc. I mean, incentives, equity, focus on policy development. We can forget also, stakeholders involvement in this process and long-term sustainability of every project or programs that we create. We need to think about sustainability.
Mr. Baez, ¿qué es lo que mira en 10 años diferente o mejorando? Iván, en 10 años, ¿qué quiere ver diferente?
Bueno, no sé si me están dando la oportunidad porque estoy con el traductor, pero me uno al sueño de todos los colegas que están aquí. Una de las cosas que siempre nosotros enfocamos es qué queremos para el futuro. Y sí, ya estábamos soñando con lo que es una clínica especializada, con un área exclusiva para atender a nuestros participantes, para poder ofrecerles actividades lúdicas, ¿verdad? Que puedan, o de entretenimiento, que puedan unirlos para seguir fortaleciendo lo que son los grupos de apoyo, porque hoy día el concepto familia se queda corto. Hoy día el concepto familias es más importante en plural, porque es la persona que es el apoyo de ese participante, que no necesariamente es su grupo consanguíneo, pero que sí le acompañan en el peregrinar, ¿verdad? De su condición, de obtener sus medicamentos, de tener sus buenos tratamientos médicos. E indudablemente creo que eso, ya la doctora Patel, pues básicamente nos ha puesto allí el reto de a lo que debemos aspirar, ¿verdad? A este enfoque donde se ofrezcan todos los servicios en un mismo lugar y sobre todo lo que caracteriza un hogar es lo cálido, ¿verdad? La calidez con la que se ofrecen los servicios. Y yo creo que por allí es que tenemos que comenzar, ¿verdad? A ofrecerle esa bienvenida a nuestros participantes, que se sientan bien atendidos, que sientan que nosotros somos su familia, que pueden traernos sus preocupaciones, sea cual sea su preocupación, ¿verdad? Desde un enfoque biopsicosocio-espiritual, que se puedan atender cada una de esas preocupaciones con buenos tratamientos, con buenos profesionales, pero sobre todo con personal humano que puede acercarse y darle la mano para lo que sea necesario. Soñaremos y seguiremos trabajando para que eso sea posible.
Gracias. Dr. Patel, how do you see the system changing in 10 years?
Yeah, and I will tell you, you didn't say there was a cap, right? So we want we want everything. I'll just add that along with this this entire network and care coordination centers, we talk a lot about that in Houston too, of where people can go into whatever's near them and help get navigated to the resources versus going all the way across a huge city here. I'll say making sure that we can include community voice in developing what we are going to develop in 10 years. Be optimistic about that and making sure that patients still have autonomy, right? Autonomy in their decisions of where to go and where to get services. So that we don't take that away.
Thank you very much. I appreciate that. We have less than 2 minutes to go. And just in closing, and Gustavo, any thoughts that you want to share about the discussion?
Definitely. I heard a lot of very valuable insights here, especially, and I want to hone in once again what Dr. Patel said, because I saw it recently, right? This individual was transitioning to older care, aging care, and the professional was not used to the kind of handoff process that we do in HIV care, but they were living with HIV. And the person was so frustrated. They came to me and they said, I want to leave it. This is a communication issue. If this works, if this doctor works for you, let's just teach each other how to talk to each other. Because if not, you could be losing a good resource. So I think there's a lot of training. I heard that a lot of need for training. But I also specifically heard a lot of hope for what's coming and for the work that is already being done in Puerto Rico, in New York, everywhere else. So I'm very excited to what's going to be coming on in the future.
Thank you so much. If anyone in the audience would like to also reach out to us and talk about what they're experiencing in their jurisdiction, they're welcome to email us and share their ideas. We want to make sure we come up with a nice document about addressing this issue, a 4-pager document. And the idea is to really talk about what we're experiencing. I've been HIV positive for 16 years. I'm 51 years old. And I want to make sure that the system is ready for me. These are things that are very important to me. So we all have a little skin in the game, and we must have community participation, community involvement from the academic side, from the mental health side, from the primary care side, and also from the infrastructure. The AETCs are so integral. We have relied a lot on our AETC to really talk about this issue and bring it to the forefront in our AETC. But other AETCs are doing the same work too. What's good for their area. Hopefully, there is a lot of geographic variation from Puerto Rico to New York to Texas to California, Florida. We all have different aspects. We all have different capacities. It's not a one time fix kind of thing. We have to have variety, flexibility, and the funding has to be there. And leading with good policy. I appreciate all of you for your time. Thank you so much. Thank you, Dr. Brennan, Ivan, Ms. Fernandez, and Dr. Patel. Gracias. Thank you so much.
Thank you.
Thank you. Bye, everyone.
Thank you.
Thank you.